Okay, good morning and welcome to Dr. Phoebe Leith and to our other therapists gathered this morning. I'd like to introduce Dr. Phoebe Leith, who is a pediatric anesthesiologist who is at the forefront of ketamine treatments, offering them here in the shoreline of Connecticut. Dr. Leith, I'm going to turn it over to you.
Thank you so much. And I feel so blessed to have met Brianna. And I did give a ketamine lecture to the Shoreline Child Psychology group in January of 2020. And I've been studying and taking all these courses ever since then. And I had to add a whole bunch of new slides just to make sure that we were current and fresh. And I'm so excited because what's happening is very exciting. There's been a lot of collaboration because we know that if ketamine therapists and psychotherapists work together, you have amazing outcomes. And so I'll go into sort of what is ketamine do, what do we expect, what am I doing in my office, what is being offered in the community, and each of these topics I could do an hour lecture on. And I would love to meet all of you in person or have coffee with anyone individually. I'm looking to foster relationships between practitioners so we can link arms and work together to stamp out dying of despair. So let's see what we have. So I'm a pediatrician. I'm a board certified pediatrician, a board certified anesthesiologist, and I did a pediatric anesthesiology fellowship. And I worked at Yale for years and years and did pediatric pain service there. So I have a lot of in-hospital experience. And then I do outpatient now. And then I started a ketamine practice about 3 years ago when I saw all this compelling data. And so I'll tell you about my practice and maybe the comparison between other practices in the area. So here's my name, even though it says PJL, I'm Phoebe Jane Leith. And a lot of people who are giving lectures on ketamine are paid by drug companies or they're being paid to speak. I have no disclosures of that kind. I'm independent. I'm doing this because I love it and it's important and I need to get us all together. I did find out today that Yale has a conflict of interest with Spravato, and it's on all the slides of all the Yale people. I didn't really realize that, but Big Pharma has a big footprint in what we do, and so does insurance. So those are things that we can work with and work around. And I know that if we work together, there will be plenty of hope and plenty of breakthroughs. So this is an old drug, ketamine, with a new application for psychotherapy. My objectives in this lecture are to introduce outpatient intravenous ketamine as a therapeutic modality, as an adjunct to your practices. I also, as I mentioned, would love to foster collaboration between all the specialties for a multimodal, synergistic approach. And there's plenty of studies to show that it matters. If you put everything together, it works that much better. I also want to talk about S-ketamine, which is called Spravato, which is subsidized by the drug companies, and IV ketamine and the difference between them, the efficacy and the cost. I also would love to stimulate further discussion about integrative therapeutic approaches and management ideas for long-term improvement and remission. So the history of chemistry goes way back 50 years, maybe more. 1964, they started the first ketamine trials. And then Park Davis started marketing Ketalar, and it was used widely. They even used it on the battlefield to get the soldiers brought into the medic tent because it's such a profound analgesic and dissociative. Then in my pediatric field in 1970, it was approved for use in neonates, children, and the elderly. So we were able to use ketamine on everybody, and the FDA decided that it was a very safe and effective anesthesia drug. So we in anesthesia use it for cancer pain, chronic pain syndromes. We use it outside the operating room, certainly in the ER, in the intensive care unit. Also, certainly we're trying to spare opioids and benzodiazepines when people have surgery. And what we found is that giving ketamine is incredibly effective at decreasing use of opiates and benzodiazepines postoperatively and in chronic pain syndromes and in general, it turns out. Also, we would use it for preoperative sedation in pediatric patients. So we had a wide use of anesthesia, and I've been using ketamine for 30 years. So, and I've been changing, altering the level of consciousness of people and managing them in a different state of consciousness for 30 years. So,
And Dr. Leith, you
sure.
had said that has this also been used with pregnant women?
Oh, that's a terrific question. I know they looked at it with so exciting. I think no, because I think it's hard to get approval, but I'll write it down as a question and start researching it. But I know that they were worried about immediately postpartum because everyone gets, well, not everyone, but postpartum depression is punishing for the child and the mom. And it would, and people were like, well, could it cross in the breast milk? Is that a problem? Is it okay to give it to someone with severe postpartum depression? And those studies are very positive. It works. There's no problem with the mom or the baby. Pregnancy, it's a harder thing to get approved and regulated and studied in the human ethical committee things. So
Sorry to derail you. I thought that was
it's
one thing.
wonderful. No, but that's really wonderful because this is what I'm all about, is making sure that everyone realizes how safe and effective this drug is and for how many things. And it's so interesting, like that you can almost there's a few things you can't fix, but it improves the perspective. We'll get to that. But
Okay, I'll go.
I'm trying not to get really excited because I just feel like this is so important.
Okay.
So then we discovered, oh my gosh, we knew that ketamine could prevent chronic pain syndrome. So we at Stanford, where I did my anesthesia residency, we would give little doses of ketamine before procedure in the operating room to tie up the receptors, the kappa receptors that would make the spinal cord spin out of control and cause chronic pain. So we were using ketamine in sort of innovative ways way back 20 years ago. But the studies started coming out all across in lay press in 2016. Jerry Sanacora has been studying it at Yale for a good 25 years. And there are some people who have been giving all kinds of psychedelics for 50 years. So I've been following their work to see what they know that could inform us in this day and age in our current practice. So I'll let you know if we can get a group together and just continue to increase our knowledge and increase our ideas about how to help this go forward. I think that would be really beneficial. So anyway, they started looking at ketamine for acute management of depression. Before that, they had done it with alcoholism, and very positive studies for the depression and the alcoholism. In order to, did everyone see that enough? So there's this was mainly just to show the date, and that it's published all over the literature. So people started giving ketamine as an outpatient around about 2016. And so I've been doing it for about 5 years. This is just to help understand how it is that ketamine works. What's the mechanism of action? And it has this really interesting multiple receptor chemistry. So it works on NMDA blockade, MAOI, ceruloplasmin, they're dopaminergic, and beta endorphin. And there's kappa and mu receptors. It's just like some of those sort of herbal remedies where if you try to distill out the piece of it, it's like not going to work. You have to get the whole thing into the patient to get this pronounced synergistic effect. So what happens is you get, because of all these receptors, you get anxiolysis, so the patient will just feel their anxiety lift. They also have profound analgesia and recovery from any pain that they're suffering. Like I have my migraine patients go, "Oh, my migraine's gone. It's amazing." Or my back pain or my leg pain or my sciatica, which is nice because it kind of undoes that neural pathway that continues to propagate. And if you can stop it, you might make some progress in completely disintegrating a pathologic pathway. It also, I'll show you such exciting slides. It's also really neat in the effects on neuroplasticity and neuroconnectivity. So I'll show you some slides of that. This is a receptor slide. And so there's a 1 next to, here's ketamine going in, and here's like a little GABA interneuron blocker. And then here's the AMPA receptors and the BDNF, and there's all kinds of things, rapamycin. And so what people try to do is distill out all the little parts of ketamine and see if they could sell a drug, because there's a profit motive, right? I mean, if you just give the drug, it's off patent, it's really cheap. So if they could like get some piece of it out, patent it, and make everyone pay a lot for it, then the drug company wins. So it turns out it has to all kind of work together to get the incredible response rates that we see. So that's one thing we've learned from the science with people studying this and going, what if you got a BDNF receptor? And they're like, doesn't work. Okay, so here's what happens when you give ketamine to people. So you have a patient who is shut down. They have parts of their brain that just aren't working. This is like, they'll describe clinically being stuck or just not getting it together, or their motor responses are slow, or they're just not being able to even access their own cognitive skills. And after you get the ketamine infusion, so these are functional MRI scans where they put one patient in the MRI scanner and said, okay, this is what part of your brain lights up before ketamine. And then they said, this is the part of your brain now that we're doing the scan that lights up after ketamine. And so this sort of explains, oh, here's a neat one too. This shows strengthening connections between brain cells. So you have all this augmented interconnectivity. And if you see the top and the control here, these are dendrites. And there's these little dendritic spines, these little blobs that come out. And see in the control how all the little blobs are kind of yellow and they're not showing up. They look like they're fading. They look like fading stars. And then the great thing is when you get ketamine, you grow new dendrites. And so it's really cool. So this shows the growing of dendrites, and all these new places where the arrows are places where they have new dendritic spines. And you can see some of them are rose de novo. Some of them are just healthier versions of what was in the control. And some of them they're just like, oh, well, I'm supposed to be here, so I'm going to express myself now. I love this slide because it's sort of what we deal with every day. The top one is what happens when you have a neuron that is stress sensitive. So the little red ones are ones that can get snubbed if you're under stress. And you know what people look like when they're okay, and then they get stressed and they turn gray, and you just know the minute they walk in your office. And so these are the little guys who are sensitive. So when you get stressed, the sensitive guys just like get ablated, and it just wrecks your brain, as you all know. And then when you give ketamine to this stressed brain that is shut down, sure enough, you will you will enhance the stress resistant dendrites. You will restore some of the dendrites that got obliterated by the stress, and then you'll grow new dendrites. Like, how great is that? And for those who want to know what the dendrites look like, that's that little spidery thing in the bottom. So I just thought that was thrilling. I'm like, I want to go grow some dendrites. All right. So what they found, not surprisingly, with all these great receptor chemistries and all these possibilities for brain connectivity is, in fact, they were getting response rates back 25 to 100%. And I have actually seen that. Like, people get better, and it's stunning. The great majority of people get better. And I'm not surprised by the 100%. It seems a little bold to broadcast 100%, but I can see where they got that. Now, what we're going for is long-term remission rates. And again, the range is ridiculous, 8 to 80%. Well, gee, if you got an 80% remission rate for someone who was stuck and wasn't making it through with the oral medicines and the psychotherapy, it'd be nice to get a long-term remission. And even if you can get these people well for a day or a week or a month or a year, it changes their life, and they have scaffolding to build on. Like, what was it like when I felt okay? And can I recall that? And can I build upon it? So it gives you these, but you can't do it without you guys. Like, you need to have the integration. You need to have the continued reinforcement of good patterns, and lay down habits for cultivating great epigenome. So we need to continue to work. Okay, let's see here. So that's that. Okay, so then it turned out it was great for not only depression, but pretty much everything. Depression, bipolar, OCD, anxiety, PTSD, trauma processing, stuckness, suicidal ideation, and transitioning. And I've had a few experiences with patients who were dying and were concerned about what the other side looked like. And certainly it's been studied, and it's in the literature, that psychedelics and ketamine can help patients become more accepting of the transitioning process. So the grief and the fear is lifted, and so they can transition in peace. But it, requires the opening of all these things, and seeing things in a new perspective. The other transitioning I've seen is when kids who are getting bullied in school because they're different, and then some of the kids have gender dysphoria, or they are trans, and they are in the process of transitioning, and the ketamine helps them rise above all the talk that is not them, that is not healthy, that other people are other people's narratives. It helps them reject other people's narratives that are damaging, which is nice. So that's a neat thing to do for kids who are struggling in that way. Okay, so huge expanded role. Now, everyone says, oh, well, what if they get tolerant to the ketamine, which can be a problem over long term? And what are the long-term effects? Well, I had a very intimate experience with tolerance and long-term effects when I was a pediatrician in the pediatric burn unit. And these babies, they had pulled a hot cauldron over on themselves. And so they had burned their skin, and they were in the intensive care unit, and they're really sick, and they were sedated. But as you know, the opiates, the benzodiazepines, quit working. We just had so much because they were in so much pain, and it was really hard to do burn dressing changes, because I had to do burn dressing changes every single day. And so and propofol wouldn't work. So we're trying to put these people to sleep, and they're so tolerant to everything. And the only thing that worked was ketamine. And so we gave ketamine to these babies every day to change their burn dressings. And there was no tolerance, there was no increase in dose week after week. And the kids had their burns healed. And we had we had kids who walked out of the hospital and did great and didn't have a single memory of the traumatic experience of their burn changes. And to me, that was very telling, just from an anesthesia perspective, because we just looked at this like nothing's going to work, and then this ketamine arose. So I've personal experience. It's like it does seem to turn out okay, and the kids didn't get tolerant. So tolerance and addiction are unlikely with ketamine or any psychedelic modality. So it's not just the ketamine. I'm taking a course, which I'd love to give a lecture on as well, on psychedelics, which they think are going to be legal for you guys in about 3 years. Psilocybin, MDMA, love to talk about that. So many wonderful things to talk about for people who are interested. But the psychedelics are great, and ketamine's great because it doesn't cause tolerance and addiction. It's just not that kind of drug. Physiologically, there's no need for it like you get with opioids or benzodiazepines. You don't have that your body clapping back and go, I need more right this minute or I'm going to melt down. There is abuse of ketamine that's reported, and interestingly, some of the abuse is associated with people who write prescriptions for ketamine, which I certainly don't, and don't know how that would actually work. But it's most common in with the portable forms of ketamine. So if you give them little oral lozenges or a nasal spray that they can take home, or even intramuscular, we're like, here, go trip on your own. Those people can take it as much as they want, and you're not in a medical setting, you're not in a therapeutic setting. So that to me is a place where abuse could happen. It's very unlikely uh, that the ketamine would be abused in a therapeutic setting, certainly. Um, and there are people who have access to a lot of ketamine, and it's just like anything that people who just want the pain to stop, they'll sniff paint, they'll do nitrous oxide, they'll do glue, they'll do whatever. And if they happen to have a whole bunch of ketamine, it just they want to get away from where they are. Those people who are doing high dose daily ketamine, I'm not sure who has all this access to ketamine, but the people who do stuff like that for a year, like 365 days of high dose ketamine, those people, those kids actually are getting bladder dysfunction. So but I just don't see that. It's just not happening in the IV therapeutic setting because we don't use high doses and we don't do it every day. So watching, waiting, not seeing it. Okay, so what do I do for office-based anesthesia? We've all heard stuff about Yale and their Spravato studies, and all our patients are like, maybe if I got in a study, then it would be free, and maybe I'd get better. And I realized that's so helpful and so terrific, and it helps Yale, but it doesn't always serve the patient. And if the patient gets placebo, then they're not getting maybe potentially the help that they need. And and in the drug trials, mostly what they're doing as researchers is gathering data and not doing therapeutic interventions to help the patient along the journey. It's mostly, let's get your score. We just need scores so we can tell if this is working. So my office-based intravenous ketamine practices is one-on-one. It's very holistic, comprehensive. It's not a clinic where I have like 10 people running at the same time. It's not a place where I give ketamine and leave the room. I sit right there with the patient who's on ketamine, and I guide them through the entire journey and help them through any challenges. And so I'm there for the beginning, the entire infusion, and I can change the rate too, which is so great. So we can go, if they're not getting enough, I can turn it up. And if they're getting too much, I can turn it down. And I could just, it's really nice. Unlike many of the other routes of administration, you have complete control, and you can get feedback from the patient about where they are and where they need to go. So you can use this to guide your therapeutic intervention. So it's so cool. So I designed my own practice, designed my own business, did it the way I wanted to do it. It's not a huge moneymaker because I only do one patient at a time, and I spend at least 6 hours with them, 2 hours for the treatment, a couple hours for preparation, and a couple hours for integration, just for one. So, but it's the right thing to do. It works and it matters. So I'm doing it. Thank you for helping me, Brianna. Okay, so what we do is I wrote 30 to 60 minute screening intake, and this usually takes a lot longer. And you guys know even better than me, when you ask someone, what are your goals? What seems to be the problem? What do you think we can help you with? It takes a lot longer than 60 minutes because you talk about family of origin, and you talk about job, and you talk about stressors, and you talk about, relationships that are ongoing, so it takes a while, and you have this little graph of like what's going wrong here. I'm sure you guys could teach me a lot about that, but I just try to map it out as a schema so I know where we're going, or I know where we've been. Then I give them anticipatory guidance about what to expect when you get ketamine. And I'll be going over all that with you just to discuss it so you know what I do in my office. And we go over, what are your goals? What are we where are we trying to go with this? And they usually have some questions or concerns or expectations. And it's kind of cool because the brain heals itself. The brain wants to be well. And the ketamine therapist does well to hold space and nurture and support the patient and hold their hand if they need grounding, but to a little bit stay out of their way and augment the experience they have, because it's stunning all the things that come out and you didn't ask for it. It's just like, oh, this is what my therapist was trying to help me understand. And I'm like, yes, you got it. And so we have to send you right back to the therapist because now your brain is open and you're ready to take it all in. So exciting. So anyway, so I talk to everybody, talk to therapists, talk to psychiatrists, sometimes neurology, oncology. I take care of a lot of people with different things. I do a treatment infusion 1-to-1 with me, the MD anesthesiologist, over 1 to 2 hours. And then afterwards, I do an integrative session where we talk about what did it mean, explain things that seem confusing, try to put it in context, and sort of hammer out the things that they learned or that they discovered, or ways that they can go into the future with this new knowledge. So that's what integration is sort of about. Again, we could do a whole hour on integration. Okay, so my concern being an anesthesiologist is making sure that everybody's safe. And in my practice, I have an EKG, pulse ox, blood pressure cuff, and I have emergency rescue equipment and obviously training to rescue someone. And also I feel as a rescue, I have psychiatrist and a therapy collaboration. And so I can call the psychiatrist and say, I'm concerned about the lithium level, or I can call the therapist and say, this one's now reliving the trauma of X, we may want to check in. So it opens the door for a lot of great communication. And so the other side of the screen is is just kind of the things that people worry about, I would say. And, we get informed consent. Um, it's just sort of a list of risks and benefits. I think this will be better delineated in a better slide that we're about to come up on. But you have to screen carefully and keep in mind the ramifications of what could go wrong, what could possibly go wrong. So screening for ketamine therapy. So part of this process is I spent a long time talking to the people and seeing if they would potentially have success, because I don't want people to waste their money or their time in trying something that is going to make them feel like a failure. So I want them all to get better. So the exclusion criterion, if they're on a bender with drugs or alcohol and they've been coming off and coming on and withdrawing and they're in an unstable pattern, recovered alcoholics are great. Recovered drug addicts are great. Those guys do terrific. But ketamine's a really powerful anesthetic drug. And we don't want a lot of this powerful stuff interacting, because it may blunt the response or it may cause hemodynamic problems, which I can fix, but it would probably freak out, people who weren't used to giving medicines to control blood pressure and heart rate. If someone's acutely psychotic, we don't do ketamine on them. We discussed high blood pressure that needs to be taken care of, and tachycardia before they come in. Ongoing vomiting, you're giving an anesthetic. You can't give an anesthetic to someone who's perpetually vomiting, but I start an IV and I give them anti-nausea medicines, and most of the time I can keep it under control. If they have elevated intracranial pressure, ketamine theoretically increases intracranial pressure, so you wouldn't want to go there. So it has been shown to be helpful in head injuries, not acute head injuries. Some clinics in Connecticut will take patients who are on MAO inhibitors. Certainly in anesthesia school, they teach you do not mix ketamine with MAO inhibitors. So I've kind of stuck with that because it has a lot to do with epinephrine. And that's not something you want to fool around with, having it go way too low or way too high in an unexpected way. So I avoid MAO use. Also, if you have a patient who has an imminent suicide plan, we love getting in the way of suicidal ideation and getting in the way of suicide plan. We love keeping people out of the emergency room in the hospital. But if I'm looking at someone who is not going to make it through the night, I want to have as organized approach to getting that patient a higher level of care that they need until we can get them stabilized enough to get treatment. Predictors of positive response. I think I mentioned family history of alcoholism, recovered alcoholics. Anyone who's had trauma in childhood tends to respond well. People who have inflammatory conditions, and this seems to feed on each other, the more inflammation you get, the more the psychiatric conditions come out, the more the anxiety, the more the depression, the more snubbed down on those dendrites. And ketamine has an anti-inflammatory effect. The other cool thing is once you get ketamine, it opens you up to do all these things you're not doing when you're shut down. So I've gotten people to eat spinach, go for walks, do meditation. I mean, like, it's so great. They're like, I've never done this before, but look at me. So it will decrease their inflammation just by nurturing their body. Because now they have the ability to get over that hump of like, I'm not doing anything. I'm too depressed. People who are over medicated, and it's not unusual for me to have a patient who's on 4 medications. High dose benzodiazepines are known to suppress the response to ketamine. Same with Lamictal, and same with daily, heavy, multiple time cannabis use. So you can get around the cannabis use and the benzodiazepines because most people are on low dose. But if you see somebody who's really, has really high use, chances are you're going to have a blunted effect. The other predictor of positive response is ongoing therapy. So you have to have your therapist, you have to have a support plan for your ongoing therapy. The ketamine just gets you started. Then you have to build the system that's going to work and build on top of that scaffolding and the new freedom that you have. And develop a healthy support system. So if you're in a couple of bad situations, maybe you could kind of peel off and go. I would love to talk with you guys about group discussions as well, because in the chat groups I've been doing, people have really said nice things about that, and that's something you guys would be enormously helpful doing. All right, so this is just what I do. These are the instructions I give my patients. I have a form for informed consent and talks about the risk and benefit. I talk about the importance of an ongoing relationship with a therapist. I tell them about the fasting requirements. They can't eat for 6 hours prior. Absolute abstinence from street drugs, alcohol. That's not allowed. We're not doing that. Cannabis is separate. If you're on a benzodiazepine from your doctor, that's separate, and we'll look at the dose. Everyone needs to be accompanied by an adult. They need to drive them there and drive them home. The people cannot drive. It's like an anesthetic, and their judgment may be impaired. So no heavy equipment the day of treatment. So, and I ask them to just sort of honor their experience and to just spend the rest of the day integrating if they can. And if they want to go for a walk at sunset or pet your dog or eat lettuce, do something that will nurture you and feed on this improvement that we're working towards. The day of therapy, I have comfort items in my office. I have a sofa and a chair. And so the patient usually lies on the sofa, and I have a weighted blanket and a sinus pillow that keeps the light out, and it puts pressure on your sinuses, which feels kind of good, and it comes down over your ears. And the monitoring we talked about. And I'm always there for a verbal check-in. I will ask a couple times as we're going in, how are you feeling? Are you feeling the effects yet? How does it feel to you? And then at some point they'll say, oh, this is great, or I'm going somewhere. And then I say, well, do you want to tell me about where you're going? So we'll kind of sort of, this is during the infusion of the ketamine. So we want to optimize the experiences as they happen, which is why constant presence and going with this change in consciousness, I feel, is really important. I couldn't just go in and out and follow what we were doing in the patient's trajectory through this journey and experience. So I stay with the patient, hold their hand, sit by the bedside if they want. So I treat nausea, hypertension, sometimes anxiety can be side effects of any psychedelic or ketamine, and those are not unique to ketamine, but I can treat them. I have an IV, so I give a medicine for nausea, a medicine for hypertension, and I can always pull back the drip rate and then see where we are. But I have rescue medicines too. So I have really good control over the experience. So people aren't going to have a bad experience because I can change stuff to customize it to what they need for where their brain is on that day. So it's very patient-centered. So it takes 5 minutes to get to steady state. Then you're in the therapeutic state, and we do the cognitive interventions as I discussed, and then we do debriefing after that. So this just shows what we're doing. These are kind of phony axes, but this is your plasma level. So you start to begin the infusion, and it goes up the pink line here in the initial phase. So you're climbing. Your level of your ketamine in your blood, now it's going to your brain. And now it opens up this therapeutic window. And you're like, wow, I'm actually in control of my OCD. My OCD is not in control of me. And you can capitalize on that because you're like, right, okay, what are you going to do with that? And so you can have this conversation. And then every once in a while, they're like, where am I? And I'll be like, you're right here. I got you. And I'll hold their hand. So this is during the therapeutic window. And then the ketamine starts wearing off after the whatever 20, 30, 40 minutes infusion. And then as it's wearing off, we do more of the integration. What, what happened? Let's try to explain that. What kind of new insights did you find? What new changes did you come up with that you might want to make? And so the therapist is just there to facilitate the process and also to make sure that all the side effects are managed and that the patient is safe and monitored throughout. The neurophysiologic effects of IV ketamine is so exciting. You get new brain interconnectivity, which we saw in the slide with the brain, and you get the dendritic growth that we talked about, the neuroplasticity, where you're actually growing new neurons. And they say your brain can't recover after injury. Well, that's just not true. What we're finding with this is, if you've had this trauma and you're all shut down, you will reestablish connection. The other cool thing is it's anti-inflammatory and it decreases inflammatory markers. And remember, we talked about how inflammation can cause depression, and then depression can cause more inflammation, and it happens with everything. Stress. Okay, so those are nice. And then you get the clinical effects, which are so much fun during IV ketamine. The patient has insight and they feel joy and they have this different perspective, sort of like a TM kind of state where you sort of rise above your problems and then you can look at them more analytically instead of feeling a prisoner of them, which is really a fun place for someone who feels like they've been locked in this cage for so long to get out and go, oh, is that what that's all about? So then it helps them identify blocks that they're having in their progress in psychotherapy. Sometimes we do reframing of, they'll go straight to a traumatic event. And I have a couple people who were raped by priests when they were little kids. And they want to go back. They want to go back and talk to the priest. And so they go into this transcendent state and I'll go with them. And then we'll talk about, how the lines were blurred and how, you were made to feel like a bad boy, like a guilty boy, like a boy who was doing something wrong and you had to please this person and this person was perfect, the pedophile. And, in the course of one visit with ketamine, you can say, what if we looked at that a different way? What if we saw an innocent boy who was doing his best and we saw a child predator who was imposing his agenda on this child? And can we see that this child is good and that this person who tried to trap him into this situation is bad? And, sometimes they'll be like, no, I'm the bad one. No, I'm the bad one. I'm like, no, look, you're here. What are you seeing? And it changes things for these kids that have this trauma. I mean, they're adults now, but it seems to have helped. And I was sort of interested and surprised that they could go visit. And sometimes they'll even talk to the priest and tell them, how they feel now and how they've healed. So the other thing that they learn to do is engage their challenges in new ways. So the things that didn't seem possible, suddenly they think, oh yeah, maybe I can do that. The other thing is the trust in the ketamine, trust in your therapist, and trust in the universe. There's just this big sort of loving trust vibe that comes into it that has to be helpful. And the people seem open and protected and more available to therapy. And the great thing is that the integration continues with your psychotherapist. So I can do a little bit of this in the time we're doing ketamine, but then if we have a collaborative work, you can take what we got from the session and then go from there. So that's my kind of, I think that would be very cool, and I think it would be enormously effective. So things that happen to you that are considered adverse effects when you use IV ketamine to treat depression. Some of them are just stuff that happens. I told you about the blood pressure and heart rate. I can control that. Um, so that's not a problem. Some people, if you prepare them properly, the anxiety isn't such a problem, but you have to have the right set expectations, setting. You have to sort of set things up, especially in patients whose primary problem is anxiety. It says increased psychotic symptoms. Well, you're not doing this on acutely psychotic patients. I think that's a little overstated. Like, people will say during ketamine, whoa, the leaves outside look like they're singing to me, or they're waving to me. And, or wow, these colors are so vibrant. And so there's a change in perspective. And I'm not sure that would necessarily be considered psychotic. Certainly with ketamine, you feel drowsy, you have tingling around your mouth. You know, of course, you're under anesthesia, so you have sort of slurred speech, dry mouth, diminished mental capacity, which fades in like half an hour, but I still warn them for the next day that they have to be careful. One of the things that happens, I said, you know, a lot of times the ketamine will cure migraines, and but one of the reported side effects after ketamine is headache, and that's self-limited and goes away in about a day. But they're like, is headache something I'm supposed to feel? And I'm like, growing all those dendrites is hard work. You know, I'm not surprised you have a headache, but it doesn't mean anything bad. It just means your brain got like kind of overdone, and it needs to integrate all that wonderful information it got. So then after I do the ketamine follow-up and the integration, I discharge when they're stable, and I meet my discharge criterion. I do a night check-in that night, and optimally I'll talk to the psychiatrist or the psychotherapist on alternate days or that day, so we can sort of pass the ball back and forth as needed. Long-term ketamine infusions are every other day for a total of 6 days. We've been doing some sort of work with one ketamine treatment or two ketamine treatment. I had this amazing experience with a boy who had OCD, and he was so disabled that he had to drop out of college, and he couldn't get out of the shower, and he was in the shower for 12 hours every day. It took up his entire day, and he couldn't touch his phone or his computer because they had germs on them. And I thought, how in the world are they ever going to get this boy from New Jersey up to here? But they did. And we did one ketamine infusion on him, and it was extraordinary. Like, this kid was just so ready. His brain was just so ready to let it go. And then after 3 ketamine infusions, and, you know, a lot of great intervention and collaboration with therapists, psychiatrists, and the family, and me back and forth, this boy, 19 years old, was better, moved back to Canada, and went back to college after 3 treatments. And I was like, all right, then that's good. So far, doing great. So you know, people talk about this 6 to 8 day course, but I'm finding like different people need different things, and it's not one size fits all. We all are in our lives as people. We have all kinds of different backgrounds, and we have all kinds of different trauma and stresses. And I just try to meet the patient where they are and use what I have to help them as best I can. I did want to tell you about S-ketamine. The ketamine I've been using for 30 years is racemic ketamine, which means it has the R piece and the S piece. So they're an equal mixture. They're two enantiomers of ketamine. What Janssen did, because they wanted to get a patent, is they said, well, if we could separate the two enantiomers, we could market as ketamine as a drug that's on patent, and we can charge like $50,000 a month for it. This will be great. And, ketamine's cheap. It's just the taking care of people and talking to them and doing the therapy that's expensive and hard. The drug, the little vial of drug is super cheap. But the drug itself doesn't help you. You have to have all the other pieces. So anyway, they thought it'd be so great to have this little nasal spray because it's super quick, super easy, super convenient, which as an anesthesiologist, I'm not sure it's great to have quick, easy, convenient anesthetics available to people randomly. I mean, they do have a FDA approved protocol, which makes it sometimes difficult for you to get as ketamine for your patients. So you have to jump through can we get it covered? And do they even qualify for it? They are using a much cheaper administration model. There's no MD, there's no IV, there's very minimal monitoring, and there's not a person to stay with the patient. You just have them do a couple nasal squirts and then you put them in a room by themselves. And there's no real therapy that takes place at that time. And there's certainly not a person with them. So this drug has been marketed heavily and subsidized by Janssen Pharmaceuticals. Because Janssen is so wealthy and because Yale wanted to study it, they made a deal to work on developing S-ketamine and doing studies with S-ketamine. And this is, they're getting for-profit subsidies. So all the Yale lecturers have to say on their slides, we have an institutional conflict of interest because we have a financial relationship with S-ketamine. So we might favor that as opposed to other things. One of the problems with S-ketamine is it only blocks the NMDA receptors. And remember all those cool synergistic receptors? This ketamine does all kinds of things. And just blocking the NMDA receptor doesn't work very well. So the efficacy of Spravato is only 40%. Sadly, 60% of people fail. And the cost without insurance is $50,000 a month. And they have bonuses, they have, I don't know if they have Groupons, but they have all kinds of financial bonuses and help programs and things like that. But I've heard that there's a lot of hoops to jump through. And a lot of the patients have told me that it's the same price or even more. So I'm interested if someone would pay for it and we could use it for free, but it just doesn't work very well. And so if someone's really sick, I wouldn't want to give them something that I know doesn't work as well as something else. But it depends on what you can get for that patient, certainly. So it's nice to know it exists and that there are programs that might offset the cost. Other problems with nasal ketamine, when you squirt something up your nose, it depends on like if you have sinusitis or if you have a runny nose or a cold, the nasal mucosa is not particularly the same in every person. Some people have allergies, some people are on, I don't know, different medications. So just getting it in your nose properly and having it diffuse into the bloodstream is a little tricky. I meant to say the administration is imprecise because the patient is in charge. They shake up their little nasal spray and they can do like several without anyone kind of noticing. So they could potentially overdose themselves. They're like, oh, I just got a half a squirt. So it's not super precise, the administration. I was discussing more bioavailability. So you don't know, it could end up in the right place. It could be like stuck on something that was in your nose. The absorption is erratic, so you're not sure how much you're getting absorbed. You can titrate it. If you squirt a bunch of stuff up your nose and it gets absorbed, that's it. You can't bring down the level if the patient is uncomfortable, dysphoric, freaking out, not at a good place, where you actually may cause more trauma. You'd like to get out of there. And you can get out of there with IV ketamine, but you can't get out of there with anything that you've given, like IM or in the nose or even oral. Those things you can't dial back. And they have this minimal monitoring system, so they certainly don't observe people as closely. Also, there's a portability or abuse potential with the nasal spray. I think some practitioners are actually giving the patient nasal spray. And, I haven't heard a lot of talk about, them sharing it with their friends or using it at parties or on the street or whatever, but it's a little bit different model that we're sort of waiting to be seen, but it just doesn't work as well. And this compares the cost and the efficacy. So if you have all these people lined up and you give half of them IV ketamine, which costs about $500, and you give half of them nasal ketamine, one treatment of each, $550, 70% of your people on the IV ketamine will respond, and only 40% of your people will respond from the nasal ketamine. So I thought that was a little bit, I don't know, I want all my patients to get better. I would be disappointed when they want to get better yesterday. Some of them are so desperate. They're just like, I've been fighting this for years and years. I'm about to give up. So I don't want to use some wimpy thing that won't work. So our goals for therapy, all of us together, are to improve efficacy, get people out of despair, get them functional, get them on a good, healthy path, and also to do that with collaboration and safety. And the things I dream of are comprehensive care, where we involve many aspects of the patient's life to help us to create a working system. Also, a multidisciplinary approach where we reach out to different groups and make and all contribute our particular skills to help the patient recover, because it all matters, and you don't know which one necessarily will resonate with that patient. But if you have plenty of people under the same roof that you can send the patient to, you can come up with a program that will give you what we're looking for, the long-term improvements and prolonged admission, and just a terrific transition out of despair. So we like to see integrative approaches, trauma-informed approaches, more holistic approaches, and working inside the family structure for a plan, a long-term plan that will work, and also respecting and honoring people's traditional and cultural beliefs during the process. I did want to show you this slide. This is from Wilkinson at Yale. And I just thought it was so neat because it's just my big cheerleading pom-poms for using CBT with ketamine. And it turns out any therapy with ketamine is going to make a big difference. Ketamine opens the brain up and the therapy gets in. And so the depression goes way down initially. So you get incredible decreases in depression severity scores. And the gray box is when they're actively getting ketamine over 1 to 3 weeks. Then these are weeks on the bottom that you come out. CBT is cognitive behavioral therapy. Tau is treatment as usual, which is, I guess, I don't know, keep taking your SSRI or something. So when, so you see, if you do the treatment as usual, they are a little bit better, but in the end, they're not that far from where they started. Um, if you add CBT, there's a huge difference between what kind of response you're getting. And this went down and then it went further down. No more ketamine. We just have CBT winning right here. So I wish I had a pointer. I'm so excited about this slide. So it just shows how important it is to marry the two because it matters. And that's a matter of fact. So I have gotten all excited. I've done all these fellowships in integrative psychiatry to sort of see about what's happening in the future. And some of the really neat things they talked about were integrative approaches and adjunctive therapies. And this is just a list of kind of my dreams of bringing everything together because these things resonate with different people, but they all work with some people. And there's art therapy and acupuncture and energy healing, nature walks, meditation, breathing, herbal remedies and aromatherapy, exercise, nutrition, sound healing, music therapy, dance therapy, groups. And I just have this vision for the future where we can open things up, bring more people in, and have more efficacy. Does that make sense? What kind of questions do y'all have?
Okay, so we have a few questions here. Thank you so much for your presentation. I know that our team is really fascinated and interested. Okay, so let me see.
Thank you.
Uh,
That was great.
With neuroplasticity, does that mean that it would increase positive results in PTSD clients? And I think we're meaning like, growth and improvement as far as positive results.
Yes.
Okay.
Unquestionably.
So this one, I know that some of these you've touched on, but just to maybe reiterate, how much is a dose and how long for the result?
Oh, terrific question. How much? So this is how what the dose is or what the cost is?
Milligrams.
Oh, milligrams, right. Okay, thank you. So they have these protocols that say 0.5 milligrams per kilo. And so I think the clinics who just have 5 people going at once, they just plug everyone in to 0.5 milligrams per kilo, run it over 40 minutes, and they randomly kind of check on them at some, but they're more like lined up with the same thing going in. I have found that some people respond with less than that. I can give them, they're very sensitive to ketamine. And so less is always more. So I'll start out with a low dose, like 0.25 per kilo, like half the dose. And I'll just have these amazing responses. And I'll think, well, look at that. And then as we go through a course of therapy, I can increase the dose and I can kind of, the patient learns to work with ketamine. They learn to trust the experience. They learn to trust the guidance. And they just expand exponentially during this process. And so I can change the dose as I go along, as is indicated by this particular patient, their brain at this moment in time.
And you've said that, with dendrites regrowing, so a couple questions here is, are there implications with dementia?
Oh, brilliant question. Oh my gosh, that's so awesome. I do think that they are looking into dementia because would be amazing. And it does seem so promising. That and COVID brain and
Yeah.
chemo brain. So there's a lot of really troubling things that we think, oh, if we can actually light up connections that are shut down, if we can actually grow new dendrites, what could happen to these people with brain injury, Alzheimer's, who are just completely shut down? Could we open up this whole new healing for them?
And have you seen examples where past memories are now accessible? Where like, they had forgotten things, but okay, now that I've had ketamine,
Mhm,
it's coming back.
mhm.
Okay,
So important.
go ahead.
No, that's it.
And a question kind of, I don't know how technical you can get in, but what is the process of these dendrites regrowing?
Oh, um, well, that's a good question. That, there's probably some trophic hormone that is released and kind of nurtures those dendrites, and they feel like they're in an environment where they can grow. But I'm not sure that I've even read a paper that said exactly by what mechanism. It looked, from some of the pictures, like some of the guys were just kind of snubbed off and they just needed a little rehabilitation. But how the new ones just start forming all over the place, I just think that's miraculous.
Yeah, it's pretty amazing. Now, there was a question about folks who have used substances in the past, and you said that if they are in, if they're in recovery, that they're great candidates, but if they're actively using, they're not going to be a good candidate for using ketamine.
Yeah,
Um,
we should define using. So in even alcohol binges, some of my patients black out every weekend, and I consider that a little bit of a full stop, because we probably, and then they come to see me on the weekend and I'm like, this brain you've given me to work with is all toxed out from the alcohol, so I don't have to work around that. Cocaine, amphetamines, those are never going to work for me. A little bit of weed, not a problem. What else do people use? A lot of people are in benzodiazepines as long as it's a low dose. Same with Lamictal. It's good to be on SSRIs. What remind me what I'm answering. I just got lost in the question.
so another question, does it matter what type of past substance use they had? Like,
Yeah, absolutely.
okay, so can you kind of discuss differences there?
That's important. So we know that there's a couple different ways. Great question. With alcohol, we know that those people, for whatever reason, especially getting over alcohol, that's a whole rebirth in and of itself. But the people who are genetically predisposed to alcoholism and then beat it, these people do incredibly well. And that's a great marker. Let me think, what else?
So if they've used like psychedelics in the past, like LSD, is that
So
going?
important, so important, so important. So that's one of the, and I can share my intake form with any of you guys who are interested, but that's one of the questions I asked. Do you have any experience with psychedelic drugs? And it's enormously helpful if they have had an experience with a psychedelic drug, because it gives us a shared language that we couldn't share had they not had that experience. And most of them say, I tried it, but it was weird because I was by myself, or I was with people I didn't like, or I got scared, or I got dysphoric, and nobody was there to hold the string to my balloon. And, so we can do that bonding, like, I'll be there to hold the string to your balloon. I'll make a safe space for you. We'll have a container where we'll make sure everything goes okay. And
Not
you'll
going to
be
have any bad trips or anything.
not going to have any bad trips. And that's really nice to get an assurance.
Yeah.
And especially if you did have a bad trip, and we talk about they've probably thought a lot about why did they have a bad trip. But yeah, it's enormously helpful.
Mhm.
Um,
Um,
yeah.
so, how does ketamine affect different areas of the brain? Have you seen certain areas have different effects than others?
Um, well, there's a lot of neuroanatomy. I only have one slide, but the prefrontal cortex and the connections there all over, and then cross connections that go over the corpus callosum of all things. Like they've come up with all kinds of um, new places where the brain lights up and old places where the brain used to light up, but then got stressed into not lighting up. So to be specific, there's another whole neuroanatomy lecture about what parts of the brain light up with ketamine. And it's very similar to what lights up with LSD, mescaline, peyote, DMT, ibogaine, all the psychedelics they're studying now.
And
Um,
what
yeah.
is the time frame for neurogenesis? I guess I mean, we're not going to see this in a standard
Good.
session, but,
Oh, no,
or,
this is a fabulous question because they've studied that. And so what happens is you get, I mean, you have a clinical response. And so what you're seeing, and you're having people do MADRS scores or they're doing all kinds of different tests to follow these patients over time. But you'll see during the session, they'll have an experience that will open them up. And then afterwards, they'll be like, "Oh, I played with my dog for the first time. I went outside. I felt joy for the first time in 10 years." So you can see the neurons lighting up by what they tell you. And then the studies have shown in the literature that they continue to improve over weeks, months, and years. And I postulate that they're still growing, but the fact that they're growing and connecting, the more connections you get, the more connections you get. And so you're using all these cool things that you just put together. It's like scaffolding, and then you can build something really great.
and then somebody was wondering what type of scan is it exactly? Are we looking like an MRI or?
Yeah, it's a they have SPECT scans, SPECT, SPECT scans. Those are one form. The ones that the researchers who I quoted here used a functional MRI. So it's an MRI scan, but there's a little tiny F in front of it, and that means functional MRI. So they're looking at the functional capacity of the brain in that comparison slide.
And then we had questions about, costs and how do we set this up? So like the practicalities. So I remember that when you and I have talked, that you said it was like $500 a treatment. Currently, I mean, who knows if somebody's seeing this like way far in the future, price may have gone up or down, who knows? And then it's standard like 6 treatments. But as you said, with your fellow who went off to college, that
Yep.
sometimes it takes more, sometimes it takes less, and then there's maintenance.
Yep.
Tell us about that.
Well, I make every I make a plan of therapy for each patient independently. I customize their therapy to them, and as we go through the therapy, we tweak it with different infusion rates, different doses, and different areas that we're willing to explore over the six treatments. And sometimes that takes longer, and sometimes that doesn't take very long at all. And it's, I think, in my experience, it seems like if you've been working on something for your entire life, like 30 years, it's probably not going to get better in 1 or 2 times. You have this kid who's just a kid, and like his dad died, he got OCD and couldn't get out of the shower. And then we only had to peel 3 or 4 layers of the onion off. And then you got people who have 30 years of trauma, repeated trauma, and repeated response to trauma. And though that onion's going to take a little bit longer to peel. And so it's like a ripple effect, or an internal ripple effect. We're trying to sort of heal in waves. as we continue with the ketamine treatment. But everyone says, well, when am I supposed to come back, or what's the protocol? And I'm like, well, the protocol is pretty much based on you. The original protocol was 0.5 per kilo over 40 minutes every other day for 6 to 8 days. People are doing all kinds of different things. And I've just noticed that if I tweak what I'm doing, I can get better clinical efficacy and better results, which is what I want, because I want 100. I don't want 70. I don't want 80. I don't want anyone to not get better. So I'll just work at it during every single one. And I know there's more I can do. So anyway.
And then there was a question, of course, about insurance. Do you have any updates on where we are with that?
I do not. I have been I need to talk to some cheerleaders about insurance, because every time I talk to people about insurance, they tell me things that aren't really encouraging. And I love your system approach. If this is a dead end, what can we do to work around it? What are our options for getting more care to more people in a way that's affordable? And can we lobby the insurance companies? Can we lobby the AMA or the APA? Can we lobby the Congress people? I mean, there's a lot of societal grief right now, and I feel like we might be able to take a part in chiseling out a little bit of that and giving that little bit some relief.
So we're working on that as far as our long-term hopes to, yes, have this more accessible to everyone.
Absolutely.
But even though, of course, the cost is proclivitive to some people, as somebody who has been in the bowels of depression, and I was pregnant at the time, so that's why I ask about pregnancy. But just to know that there was something there, to even, to have been pregnant, and even if it's, you can't take this while you're pregnant, but we're going to help you right after pregnancy, to know, just to know that there are options and there's hope. And there are solutions, because that's, and for so many other things, for PTSD and OCD, and things that people have been wrestling with for ages, to know that this is accessible, and it's not, it's not going to cost you, tens of thousands or hundreds or billions or millions. You don't have to be the 1% to access this. And it might not be on your shopping list. Oh, I'm going to swing by the grocery store and get, oh, and I also have to get ketamine.
Right.
But it's not that far out of reach. And you're doing the work right here on the shoreline, and you're reaching people. And we're so excited to be creating this video to kind of share with other people, to get the word out about these treatments that are happening. So somebody was asking, well, what do I do if I want to set up an appointment? And I know that we've been working on a website with you, but I don't know if it stopped after that coffee date. I know we need to have another coffee date.
I have been working, and to get an appointment with me right now, I have people call me, text me on my cell phone, and my phone number is, and I can get you all cards. I'll visit your office. I'll make sure that you get everything you need. But right now, people will text me and say, I have been referred, I'm self-referring, I've been referred by my social worker, my psychologist, my whoever. And they text me. And that's how I'm still doing everything myself. So that's how we're starting the loop. And then I get their phone number, I call them, I have them fill out my forms if they're still interested, and we start a relationship prior. But the most important thing is my number for the moment. And my email is goodfarm, GOODFARM, the number pi 31415 @gmail.com. And my cell phone is 203-906-5158. And I live here in Guilford, and I got that office downtown. And I also would love to go out for lunch with any one of you or visit your office, because I have
We
big
still have to have you come into our office.
I know, I had a paintbrush one day. Yeah. But like, I feel like there's some magic that can happen, and I feel like there's some healing that can be done. And I feel like as a coalition, we're stronger.
Thank you so much for taking the time with us this morning. And oh, here's another, sorry, we have one more good question. Says, so insurance is still in the works. Can people use their HSAs? And I think that might be a question that you have to check with a specific HSA. That sometimes there can be different parameters. Do you have any ideas?
I know that I have prepared forms for people who are submitting it to their insurance in hopes it would be covered. And I have prepared forms for HSA.
Okay.
And most of the feedback I get is they're not buying it. And I'm like, is there anything I can do to push this along? And they said, no, they're just not buying it. So I think HSAs go better than insurance.
Okay. All right. So HSAs is a possibility. Insurance is just shaking their heads now. I mean, I know that, insurance companies
We'll
like
get there.
Anthem.
We'll
Yeah,
get
we're
there.
getting there.
Yeah.
But there are cases, we offer biofeedback in our office, which is, such a simple and effective training tool and therapy technique. And Anthem is like, well, we have seen the studies and we know that this helps with PTSD, but we want to see more studies. So we're telling people, look, $20 extra for a session, and 10, $20 extra for a session, and we're just going to offer this. We've seen it work. We know it works. And I'm sorry that Anthem's holding out, but it is there if you want it.
Yeah.
So thank you so much for taking the time with us this morning. And I will send you this video to share, and we'll put it out there.
Appreciate it.
And we will definitely be in touch for a coffee date soon.
Wonderful. Thank you so much. It's so nice to meet you all. Thank you so much for coming. And please reach out to me. I'm so open and so excited about collaborating. And if you have friends or groups that you're also involved with, I would be happy to speak with them as well if you have interest. And